Good morning, friends. Welcome back to my YouTube channel, Medical Classes by Dr. Srinidhi Kumar Acharya. Don't forget to subscribe my channel and also please give your valuable comments. So, as we know, we were discussing about history taking in detail, especially in children. So, we have seen so many parts of history taking. Now, today we will discuss about antenatal history. Now, as far as children and infants, newborn, etc., are considered, now this antenatal history is very important. Okay, so antenatal history, perinatal or birth history, and then comes the postnatal history. So these are the important parts. Sometimes, usually, few of the physicians they will take the birth history in the beginning itself, in the place of present history, in case of children. Of course, that is possible when you are getting expert, but it is better to always follow this particular order till you get expertise. Anyway, now in the antenatal history, now this is because antenatal period is nothing but intrauterine period. Okay, the baby is inside the uterus, and as Kashyapa says, Garbhavastha is also considered under the age. So therefore, antenatal period means for us, for pediatrician, it is nothing but the intrauterine life of the baby. So any events which are taking place in the antenatal period will have the adverse effects over the baby also. Therefore, this period is very important. Now, in the antenatal history, so we totally classify this antenatal period into first trimester, second trimester, and third trimester. And now the trimester wise, you have to ask the antenatal history. So first you ask what's happened in the first trimester. In the first trimester, what are the questions that you have to be asked? So in the first trimester, first you see whether this pregnancy was registered pregnancy or non-registered pregnancy. Registered means she is undergoing all the antenatal checkup, and the delivery has been taken place in the hospital under the safe hands. Okay, so that's the one thing. Then so then you should also find out how she come to know that she is positive for the pregnancy positive. So which method she has used, kit methods or something like that. Then, and this is one of the example I have given, one of the case we have given. Other things that you have to ask is in the first trimester that any history of fever, because fever coming in the first trimester is some of them are very dangerous. Okay, because they have got more complications, because before formation of the embryogenesis, before formation of the organogenesis, if the fever comes and disturbs the internal environment of DNA and all, genes and all, then the formation of the body parts will not take place, and it leads to so many problems. So anyway, the fever which is during the first trimester has to be inquired. Any type of lymphadenopathies should be inquired, and bad events like vomiting will be usually there in the first trimester, no problem. Apart from that, any other bad events which has taken, or any history of fever with rash, so that has to be taken. Okay, so number two, in second trimester, when you come to the second trimester, you have to ask different events like quickening happened in which particular month. Okay, when she start feeling the movement of the child. Okay, whether she received any iron and folic acid tablets, that has to be ensured. Then anomaly scan we will usually do in the second trimester, whether it was done or not. If done, what was the result? Okay, and whether she is received the first dose of TT or not. So these things has to be asked in second trimester. And now apart from that, you have to also see that whether this particular pregnancy is a high risk pregnancy or no risk pregnancy. High risk pregnancy where the mother is having anemia, mother is having cephalopelvic disproportion, mother is having short stature, mother is having less weight. Okay, and mother is having preeclampsia, mother is having history of fever, mother is having intrauterine growth retardation. So all these things helps us to identify the particular condition as a high risk pregnancy, that hemoglobin, less hemoglobin. So everything we have to ensure whether that particular pregnancy of this particular child, whether it is a high risk pregnancy or no risk pregnancy or low risk pregnancy. In the third trimester, what you have to see in the third trimester, especially nutrition is very important. Okay, so any maternal disorders and whether she is taking any medication for that, that also has to be inquired. Suppose the mother is a known case of epilepsy, she has to take the medicine. Mother is a known case of diabetes, she has to take the medicine. Mother is a known case of hypertension, she has to take the medicine. So which medicine she is taking? Okay, so that has to be, or teratogenic effects, and any teratogenic effect of that particular medicine, that has to be understood. And next we have to see in the third trimester whether there is any placental hemorrhages, abortoplacenta, or what you say, antenatal hemorrhages. Okay, antepartum hemorrhage, so that has to be seen. There is no any history of bleeding PV, then any foul smelling discharge which is coming out, any maternal disorders she is suffering, history of oligohydramnios and polyhydramnios, that has to be asked. Okay, and whether she has got an antenatal scan at 7th month of pregnancy, and also the TT, the last dose of TT. So these are the important things that you have to ask in the antenatal history. So that whether it's a twin delivery, one more important thing. Okay, so all these things, all these factors you have to ensure in the antenatal history. Similarly, when you go to the perinatal history, perinatal period start from the 28th week of pregnancy till first week after the birth. So the any birth event like asphyxia, etc., that is also included under perinatal period only. So what you have to discuss is, what you have to ask is about the fetal distress, any history of fetal distress, or whether there's a history of instrumental delivery, any instruments are used, or it's a vacuum delivery. So vacuum delivery is caput succedaneum, and all these are most commonly expected. Instrumental delivery, there is a history, there may be chance of a brachial palsies, Kremsky's palsies, and then fracture of the neck of the neck, fracture of the clavicle, and such history may be evident. Then you have to ask whether the history of mass meconium aspiration syndrome, which is nothing but leads to systemic asphyxia. Asphyxia is a systemic disorder. Then you have to ask about the asphyxia, whether the child is cried immediately after birth, or whether child cried after birth, late after the birth, and what was whether it is a significant asphyxia happened or non-significant asphyxia which has happened, that has to be asked. Then any resuscitation procedures done during the time of the birth to make the baby cry and alive. So then how many days the baby was kept in the NICU, and that has to be asked. And after how many days the mother started feeding the baby, breastfeeding the baby, that has to be asked. Then at the time of the birth, what was the gestational age of the baby, and what about the genitalia, whether the ambiguous genitalia, or whether baby has got any congenital gross congenital abnormalities like a tracheoesophageal fistula or something like that, pyloric stenosis, etc., and low birth, premature birth. Every aspect has to be examined. See, this is one of the example how you have to write the prenatal history and birth history. See, child was born by normal vaginal delivery at the government hospital. Birth weight is 2.5 kg. Child was a history of delayed cry for 5 minutes. During that time, supplemented by oxygen and suction. And baby was breastfed within 1 hour without any NICU stay. And there is no history of jaundice and passed meconium within 24 hours of the life. See, this is one of the way of writing this particular birth history. Okay, so whatever the points that I have described here, that has to be summarized in this way. One more important aspect in the history is the postnatal history. In the postnatal history, we have to look into the different infections of the baby, whether baby has got any infections, because late onset of septicemia, early onset of the septicemia, and different infections are most common in the babies. Okay, especially first 12 weeks of the life, 12 days of the life is considered as a high risk period. Okay, electrolyte imbalances, hypoglycemia, hyperglycemia, hypocalcemia, jaundice, pathological jaundice, hypothyroidism, some hemolytic disorders of the newborn, bleeding. So all these manifestations are quite common, especially even in the normal baby also. Post-term babies are more liable to have the problems in the postnatal life. Anyway, the infections, then feeding problems has to be checked. In the postnatal, very importantly, feeding problems has to be rechecked, especially in terms of Ayurveda. We talks about Sanya Dushtis and all those things, Vataja, Pittaja, Kaphaja, Sanya Dushti, that has to be identified, and mother should be given with the Sanya Shodhana drugs. So that's a different issue. Then look into the kernicterus, and look into the pathological jaundice and physiological jaundice, because see, in the newborn we have got so many common physiological problems in the newborn, like a toxic erythema is there, okay, or abnormal shape of the head is there, physiological jaundice is there, the gastrocolic reflex is there, and regurgitation is there. These are considered to be the common neonatal problems. Okay, that has to be differentiated from the pathological problems. So all these details you have to ask in the postnatal history, any of the evidence which is taken. So how many days afterwards the baby has been given to the mother, if it is the NICU stay history is there. So this point has to be covered in the postnatal history. So okay, so these are the important aspect of history taking in children. So we have not covered the general examination. Next point is general examination. Okay, afterwards we'll go for systemic examination, and with this we have completed the history taking part. and this has to be taken in each and every patient, especially in childhood practice. Okay, so far we have seen the vital data in detail, and next we have seen the main complaint, next we have seen the present history, then past history, then we have seen the family history, the nutritional history is there, then we have seen the developmental history, vaccination history, personal history, treatment history. Okay, so then comes the vaccination history, and then comes the antenatal, perinatal, and as well as postnatal history. So with this we have completed the history taking portion. These are the points that has to be asked to the patient without touching the patient. There is no need of touching the patient, just you are documenting the things. Okay, the next comes the general examination, where you have to need to touch the patient. Okay, so this much of information you can get only by taking the history. And after taking history, now we go to the next phase. Okay, we have to do a provisional diagnosis after taking history itself. How to do that? See, we have got an anatomical diagnosis, we have got a pathological diagnosis, we have got a etiological diagnosis. These three diagnoses has to be done immediately after taking the history portion, before touching the patient. And you do a differential diagnosis, provisional diagnosis, then by means of general examination and as well as by means of a systemic examination and investigations, you confirm your provisional diagnosis. Okay, so how to make an anatomical diagnosis, how to make an etiological diagnosis, and how to make an pathological diagnosis, that we will discuss in the next session. Okay, thank you very much. This is all about history taking. Okay, I have not covered much of the Ayurvedic portions of history taking, so that we will cover in a future classes. Thank you very much. Please don't forget to subscribe my channel, and also please give your valuable comments. Thank you very much.